Hello, my name is Casey Johnson, and I'm the Scientific Affairs Manager for Cervical Cancer Screening here at Hologic. Today, I'm going to be discussing methods and technology for cervical cancer screening and why it matters in the context of performance. Statistics show that cervical cancer affects women in the United States at alarming rates. And since 2012, the cervical cancer incidence have been increasing in women less than 50 years of age. It is important to change these statistics by providing women the most comprehensive screening strategy for cervical cancer. Co-testing, or the Pap and HPV testing, is the most widely used screening modality in the United States in women ages 30 to 65 years of age. The Pap is a cytological collection that is a snapshot of the health of the cervix today, whereas the HPV test is additive and is an indicator of the future risk of cervical disease. Today, we're going to be going into further discussions about these two technologies utilized in co-testing. And technology matters in the context of cervical cancer screening, as stated by Debbie Saslow from the American Cancer Society, where she says, the optimal screening strategy should identify those cervical cancer precursors that are likely to progress to invasive cancer, thus maximizing the benefits of screening, and avoid detection and unnecessary treatment of transient HPV infections and its associated benign lesions that are not destined to become cancerous, minimizing the potential harms associated with screening. To meet the goals of cervical cancer screening, technology is extremely important and have evolved in order to better detect disease like cervical cancer. In the 1940s was the introduction of the Pap smear, one of the most successful cancer screening programs to date. However, the Pap did have its limitations, such as its limited sensitivity, which required frequent annual screening. From the Pap smear, we had the introduction of liquid-based cytology, or LBCs, which allowed for improved sensitivity while maintaining the excellent specificity that is seen in the Pap smear. For the first portion of this presentation, we will be discussing LBCs, specifically ThinPrep. And later, with the knowledge that 99% of cervical cancers are caused by HPV, this led to the introduction of HPV testing, which allowed for improved sensitivity. And we will touch on the HPV technologies more in the second portion of this presentation. There are currently two FDA-approved LBCs, Hologic's ThinPrep and BD's SurePath. When we compare these two LBCs, we see that there are not just improvements when comparing LBC to conventional Pap, but also improvements when we compare ThinPrep to SurePath. ThinPrep is more effective than the conventional Pap for detection of LSIL and more severe disease, as well as being indicated for detection for glandular disease, which we will be discussing in more detail in upcoming slides. ThinPrep also has many FDA approvals and clearances out of the vial for molecular testing, including trichomonas. ThinPrep also has a longer cytology stability of 6 weeks at room temperature as compared to SurePath with 4 weeks. So now that we understand the comparisons and differences between the LBCs, let's dig a little bit further into the ThinPrep technology and its collection. The ThinPrep vial contains preserved site solution, which is a methanol-based solution which protects DNA and RNA for molecular testing. The vial comes with a cervix brush and a combination of the endocervical brush and spatula that can be used together for collection. Once the cervical sample is collected, the collection methodology is immediately rinsed and swirled into the preserved site solution to enable maximum cell transfer into the vial. As mentioned, ThinPrep preserved site solution is a methanol-based solution which preserves DNA and RNA for molecular testing. With the preserved site solution, it has been cleared or approved by the FDA for most ancillary testing out of a single vial. The ThinPrep vial has approval for HPV testing, as well as chlamydia, gonorrhea, and trichomonas, all from the same vial. And up to 4 milliliters of sample volume can be removed from the vial prior to cytology to facilitate these multiple ancillary testing. There are additional benefits and differences with ThinPrep when compared to SurePath as well, specifically in the context of sample collection and cytology testing. With the ThinPrep Pap test collection, the device is rinsed into the preserved site solution so that 100% of the cells collected are available for slide preparation, as depicted here on the left. Conversely, on the right, we're looking at SurePath. With SurePath, after the sample is collected into the vial, there is a transfer step to the tube, where up to 33% of epithelial cells can be lost. This means that up to 7% of abnormal cells can be discarded in this process, thus emphasizing the benefits of using the ThinPrep Pap test, that you can be confident that the cells that are collected will be well represented on the slide. These benefits can be further exemplified when we look at the slide. With the ThinPrep slide, as shown on the left, we can see that there are more white spaces and a thin representative distribution of the cells, as opposed to the SurePath slide that we see on the right, where the cells are collected into a more compact area. Studies like the Kitchener study shows that the adequacy for a ThinPrep slide is approximately 5,000 cells, as compared to the SurePath, which is about 15,000 cells. Additionally, ThinPrep is supported with robust multi-site data showing an improvement in HSIL plus detection. In 10 different laboratories, as depicted in the table here on the right side, they found an increase in HSIL plus detection as compared to conventional Pap when using ThinPrep. In these studies, all results were biopsy confirmed. ThinPrep showed an increase in HSIL plus detection of 59.7%. This has been further demonstrated in reports from the College of American Pathologists, or CAP, where more HSIL and LSIL are detected using ThinPrep as compared to SurePath or conventional Pap. As we see here represented graphically, we're looking at the conventional Pap in gray, SurePath in teal, and ThinPrep in purple. On the left-hand side, we're looking at the HSIL reporting rate, and we can see that ThinPrep has as much as double the amount of HSIL reported as compared to SurePath, where SurePath sees similar HSIL detection as the conventional Pap. On the right-hand side, we see that ThinPrep has increased LSIL reporting as compared to SurePath and conventional Pap. Another benefit of ThinPrep is that it is the only Pap test with the approved labeling for detecting glandular disease. There have been multiple peer-reviewed studies that support the increase in glandular disease detection using ThinPrep as compared to the conventional Pap. Where we see this in the Schroeg study is that the ThinPrep has over a 56% increased sensitivity for cervical adenocarcinoma as compared to the conventional Pap, as depicted here graphically. And this is an important distinction as cases of adenocarcinoma are rising, which we're not entirely sure why. With the introduction of the Pap, there have been a steady decrease in squamous cell carcinoma, whereas with adenocarcinoma, there has been a 35% increase between 1973 and 2015, emphasizing the importance of the glandular claim with ThinPrep. Beyond the benefits of ThinPrep for increased HSIL detection and the detection of glandular disease, we have continued to improve technology for better disease detection by offering ThinPrep imaging. ThinPrep imaging is now widely used in the United States, where more than 80% of ThinPreps are imaged. And studies have shown a reduction in unsatisfactory results, which we will expand upon in upcoming slides. And how does imaging work? The imager will scan the slide and identify the largest and darkest objects. As cells progress from normal to abnormal, their nuclei become larger and darker, as depicted here on the right-hand side. The imager will scan the slide and identify 22 fields of view that have larger and darker objects, directing the cytotechnologist to examine these particular cells. Multiple studies demonstrated graphically here on this slide have shown that using imaging, that there is an increase in LSIL and HSIL detection as compared to non-imaged. What we can see here in teal is that using imaging increased LSIL detection ranging from 31 to 46% in these various studies. And in blue, that imaging increased HSIL detection ranging from 6 to 42%, emphasizing how this improved technology improves patient care. Another benefit of imaging is a decrease in the unsatisfactory and ascus rates when compared to non-imaged. As demonstrated here from the Miller study, we can see that there is a 67% decrease in unstat rates using imaging as compared to non-imaging on the left-hand side. And on the right-hand side, we see that there's a 15% decrease in ascus rates in using imaging. Aside from the clinical benefits of using ThinPrep imaging, there are workflow efficiencies as well, demonstrated pictorially here. On the top portion, we see the ThinPrep imaging workflow, and on the bottom portion, we're looking at the competitive workflow. ThinPrep offers laboratories a more efficient workflow, ergonomic benefits, chain of custody, standardization, and consistent results. The competitive workflow can be more labor-intensive and time-consuming. To summarize the first portion of this presentation, ThinPrep was the first liquid-based cytology option for cervical cancer screening. The ThinPrep vial has many out-of-vial molecular testing approvals, and ThinPrep is the only Pap test with FDA-approved labeling for glandular disease detection. It is important to note that there are 25 plus years of performance data and more than 1 billion ThinPreps that have been performed, and thus there are many studies showing the benefits of ThinPrep. And technology has continued to improve beyond the Pap test, and this is with the addition of HPV testing. And similar to the Pap, not all HPV tests are the same, so technology does in fact matter with HPV testing as well. Specifically, HPV mRNA testing has been shown to have the same sensitivity and better specificity as compared to DNA-based tests, which we will discuss in the remainder of this presentation. Aptima HPV is an mRNA-based test, and to best understand this technology, we need to understand the basics of HPV. HPV, or human papillomavirus, is a family of viruses that infect the skin and mucosal membranes. What makes screening for HPV challenging is that most sexually active people will have an HPV infection in their lifetime, where most of these infections are transient and can be cleared. It is the persistent infections of HPV that are recognized as the major cause of cervical cancer. Because of this, our screening technologies cannot simply be used for the presence of HPV, but for the detection of those infections most likely to cause cervical cancer. Now, there are more than 100 types of HPV viruses that have been identified. However, there are 14 oncogenic types or high-risk types that are primarily cause all of the cervical cancer. To understand the difference between a DNA-based HPV assay and an mRNA-based assay, we need to understand the natural history of HPV infections to precancerous lesions to potentially invasive cervical cancer. The presence of the infection or persistent infection is identified by viral DNA, as depicted on the left. Subsequent viral transformation results from the expression of certain HPV proteins, like E6 and E7, which are responsible for viral replication and transformation of the host cell. Their overexpression, which can be measured as E6, E7 messenger RNA or mRNA transcripts, indicates HPV oncogenic activity and may be used as a clinically predictive marker to identify those women most likely at risk of developing high-grade or cervical carcinoma. If we look at the data for HPV clearance and progression, we see that most infections will resolve spontaneously. About 90% will resolve within the first 2 years. Persistent HPV infections, however, may progress directly to higher grades like SIN2 or SIN3. High-grade abnormalities are at risk of progressing to cancer and are so considered cancer precursors. Some high-grade abnormalities may spontaneously progress if left undetected and untreated. For years or decades later, a SIN2 or SIN3 can progress to cervical cancer. These graphs here represent the clinical changes associated with HPV infections. On the left graph, we are looking at the proportion of prevalent carcinogenic HPV infections that clear, persist, or progress to SIN3 in the first 3 years after detection. The rate of clearance is high within the first 2 years after the infection, but decrease over time. On the right-hand side, we show the proportion of untreated SIN3 lesions that can turn into invasive carcinoma within 30 years following that initial diagnosis. 20% of these SYN3 lesions will progress to cancer in 5 years and 50% in 30 years. What we want is for our tests to identify those HPV infections that are most likely to identify those precancerous precursors that are likely to progress to SYN3 in cancer, and not those transient HPV infections. If we look at this model here of the majority of cervical cancer progression, one thing to highlight is as cervical disease progresses, we see an increased level of E6, E7 mRNA. On the left-hand side, we are looking at normal cervical epithelial cells, and as we move towards the right, we have progressing cervical disease to cervical carcinoma. This slide demonstrates the pathological changes characterized as SYN induced by the expression of E6, E7 genes. Recall that nearly 90% of women with detectable HPV infections will spontaneously clear the infection within the first 2 years. It is the combined effects of E6, E7 proteins that put the cells at risk for undergoing uncontrolled division that can lead to cancer, and thus E6, E7 mRNA as a good marker for identifying these cells and thus those infections most likely to progress to disease. And as we can see, as the cervical disease progresses, there's an increase in these E6, E7 mRNA levels, suggesting again a marker for greater specificity for disease. Whereas as disease progresses, we do see a decrease in DNA levels. Further highlighting the benefits of Aptima HPV and its design, targeting the E6, E7 mRNA. As we said, E6, E7 mRNA is indicative of HPV oncogenic activity and thus focusing on those infections that are most likely to result in disease. With this better understanding of the molecular biology of HPV and progression to cervical disease, let's discuss how the design of the Aptima HPV assay results in clinical benefits with the goals of cervical cancer screening in mind, maximizing the benefits and minimizing the harms. High sensitivity provides the confidence that we need to know that no woman is returned to routine screening who actually may have underlying lesions that requires more intensive follow-up and/or treatment. The clinical sensitivity for Aptima HPV by mRNA, as shown here in green, is compared to traditional DNA methods like the hybrid capture 2, shown in purple, and the Roche-Cobas in gray. And what we can see is that the sensitivity is essentially equivalent in multiple studies in both the referral and screening populations. It is equally important to not overtreat or overdiagnose, and this is where specificity is so important. This should certainly resonate with all clinicians who experience that burden of unnecessary and difficult conversations with patients and subsequent vigilant follow-up, colposcopy, and even treatment when there was no significant disease detected. As depicted here in this graph, we are demonstrating the clinical specificity of HPV testing associated with SYN2 or greater. Aptima, again, is in green and compared to hybrid capture 2 in purple and Roche-Cobas in gray. And what we can see is that consistently, the Aptima is statistically significantly more specific than the DNA-based testing. So what does this increased specificity mean? It means fewer false positives. Minimizing false positives helps the clinicians target the right patients for colposcopy and ultimately treatment. In the CLEAR trial, the Aptima HPV assay showed 24% fewer false positive test results when compared to hybrid capture 2. In the Montenegro study, it showed up to a 40% reduction in false positives. This increased specificity minimizes difficult patient conversation, minimizes the potential for unnecessary colposcopies and biopsies, and thus minimizing the harms to the patient. The Aptima HPV clinical data is summarized best in this quote. In the comparison with other HPV tests, the Aptima HPV test repeatedly had equivalent clinical sensitivity, but superior specificity for the detection of cervical disease. Beyond sensitivity and specificity data, there is extensive longitudinal data using Aptima HPV. The first study, the CLEAR trial, evaluated the risk of SYN3 3 years following a negative HPV result. And what we showed that a negative by either Aptima or hybrid capture 2 showed a very low risk of SYN development. Since this study, there have been additional studies to provide confidence in the Aptima HPV assay testing for extended intervals. A publication from the Focal trial came out that evaluated the risk 4 years following a negative on both hybrid capture-2 and Aptima, and found that there was no significant difference between these two assays. These findings remain consistent in studies that evaluated 7 years and 10 years following a negative Aptima result. An important distinction with HPV testing is the need for high-risk screening and genotype triaging. 70% of cervical cancers are caused by types 16 and 18, and therefore have certain distinctions in guidelines for follow-up. There are 3 main HPV genotyping assays in the United States: Hologic's Aptima HPV genotyping, the Roche Cobas, and BD Unclarity. Aptima genotyping is a standalone assay that tests for 16 and 1845. The Cobas is one assay that distinguishes 16, 18, and the other 12 high-risk HPVs. Unclarity comes in different iterations with the ability to differentiate 16, 18, 45, 31, 51, 52, and have various pooled high-risk groups. The Aptima high-risk HPV assay detects all 14 high-risk HPV genotypes, including HPV 31. Our genotype assay breaks this out further, giving an individual result for HPV 16 and a group result HPV 18 and 45. From the Athena trial, it confirmed that the utility of 16 and 18 genotypes in cervical cancer screening, but reiterated that pooling the other 12 high-risk genotypes is sufficient. The Aptima HPV genotyping assay was designed with guidelines in mind. It is to be run following a positive Aptima HPV high-risk assay result, and thus can differentiate 16 and give a pooled result for 18 and 45. The genotyping testing can be performed out of the same tube as the high-risk HPV assay, so there is no need for a recollection or realiquot out of the sample. Various studies have evaluated the contribution of each genotype to SIN3+ and cervical cancer, as demonstrated here. Specifically, we wanted to highlight 3 studies: the Stoller study, which is from the Unclarity clinical trial, the DeMarco study, and the Day San Jose study. On the left-hand side, we are looking at the genotypes and their contributions to SIN3+. In both these studies, they emphasize that 16 has the highest prevalence in SIN3+. But one important distinction between these two data sets is that Stoller shows a higher prevalence of HPV 31, as shown in magenta, in SIN3+ as compared to the DeMarco study, which has decreased prevalence with HPV 31 in SIN3. The data shows that HPV 31 does in fact play a role in precancerous disease, but that the Stoller data may overinflate the role of HPV 31 with its low N. Moving to the graphs on the right, the data here we're looking from Day San Jose shows the HPV prevalence for invasive cervical cancer, broken out by squamous cell carcinoma and adenocarcinoma. You can see a much higher prevalence of HPV 16 as compared to the SIN3 data, and the decreased level of HPV 31 for squamous cell carcinoma, again in magenta. The adenocarcinoma graph shows that 94% of cervical adenocarcinoma is associated with types 16, 18, and 45. This is important to note since that adenocarcinoma, as we mentioned, rates are on the rise, emphasizing the utility and the value of the Aptima genotyping assay for 16, 18, and 45. So as we mentioned, HPV types 16 and 18 and 45 are responsible for up to 75% of squamous cell carcinomas and 94% of HPV-related adenocarcinomas. Now, HPV 45 is the third most common HPV type in invasive cervical cancer, and it identifies more women at risk for adenocarcinoma. But seeing as it has low prevalence in normal cytology, it has minimal impact to the colposcopy rates. HPV type 16 is also associated with 62% of squamous cell carcinoma and 50% of adenocarcinomas. The ASCCP provides management guidelines on how to manage different genotyping results. And here we are looking at one particular case in where genotyping would change management and care of that patient. For example, if we have a NILM cytology and high-risk HPV positive, if the patient is 16 or 18 positive, ASCCP would recommend colposcopy. Whereas if it's positive for one of the other 12 high-risk HPV genotypes, the patient would come back for 1 year follow-up. Currently, there are no guidelines for extended genotyping. And as quoted here, it states, ultimately, the placement of genotypes into risk strata will require consensus from multiple prospective and observational studies and modeling studies that provide risk estimates and corresponding number of colposcopy referrals in order to provide an accurate risk-benefit analysis. A lot of data is required to make these changes to guidelines, and as I stated, as of today, there's not enough data that suggests that type 31 or extended genotyping needs to be treated differently than the other 12 high-risk types. To summarize, the Aptima HPV assay targets mRNA that identifies the presence and activity of high-risk HPV infections. From multiple studies, it has been shown to have equivalent sensitivity to DNA-based tests with superior specificity. We have multiple studies that have now shown over 10 years of longitudinal safety data using an mRNA-based assay. The Aptima HPV genotyping assay was designed with guidelines in mind and provides a targeted approach with HPV types 16 and 1845. Types 16, 18, and 45 are associated with up to 94% of HPV-related cervical adenocarcinomas. And with that, thank you so much for your time. For more information on our products, please visit hologicwomenshealth.com.